Good morning, one and all. Welcome to this special session on basics in pediatric arrhythmias. I'm Dr. Deepchand Raja, one of the program coordinators. We have with us Dr. Atul Prabhu, who is in fact the prime coordinator who has taken all the efforts in designing the agenda for this program. Welcome, Dr. Atul.
Thank you.
So we have uh, a warm welcome to the moderators, Dr. Ajay Nayak, sir, President of the Indian Heart Rhythm Society, Dr. Amit Vora sir, and Dr. Sneha Kulkarni madam. In fact, I must say that at this point, that it was our President of IHRS, Dr. Ajay Nayak sir, who conceived this very idea of bringing and the collaboration with the Pediatric Cardiology Society of India. So over to you, Ajay Nayak sir, for the opening remarks, after which the moderators can start the webinar.
Yeah, thank you, Deepchand. Thank you, Deepchand and Atul for putting this together and Medgami for supporting this. It's really nice being here, 300 plus registrations for this program. And this program was originally thought of by Dr. Snehal Kulkarni and Dr. Yash. It was very important that pediatric cardiologists should also have exposure to EP. And we in EP are practicing EP where we have to take care of patients from neonatal age till 100 years of age. So we need exposure for that, for that also. So this was an excellent idea to put forward, and we are going to carry this forward. Pediatric CSI conference will have a EP session, and IHRS will have pediatric sessions, and moreover, for convenience to all, we have a WhatsApp group going with pediatrics, cardiologists, and uh, electrophysiologists. So these are all associations. Dr. Snail was the lecturer when I was doing residency. Dr. Yash, Dr. Amit have trained me. And it is nice to have old friendships and old colleagues bringing forward societies and professional organizations to create a sort of legacy which can be continued to be maintained for the future. So thank you for everyone for this. We have an excellent program today. There are first couple of sessions will be by Dr. Atul Prabhu and Dr. Suresh Kumar. And then we have three cases by Dr. Ronak, Dr. Kishore, and Dr. Sneha Keswani. So a brief word by Dr. Amit Vora and Dr. Snehal Kulkarni, and then we'll just move on to the first talk by Dr. Atul Prabhu.
Yeah, thank you, Ajay, a lot. Actually, I sincerely thank IHRS to get the Pediatric Cardiac Society together to work together and really get a meaningful outcome out of that. And thanks a lot for this initiative. And I'm sure with your help, we'll keep on going periodically on this platform together. So the first talk will be by Dr. Atul Prabhu, and always one question is the pediatric heart is not a small adult's heart. In all aspects, the problems are different, the heart defects are different, and therefore we need to see this pediatric heart in a different way than we see the adults. And Atul will talk about is the pediatric ECG same as a small adult ECG. Over to you, Atul. And Amit.
No, I think I'm quite excited about this webinar myself, and yeah, it's an interesting line of talks. So over to Atul Prabhu in terms of guiding us more about pediatric ECG. Is this the same as that of a small adult? I would have liked to rephrase the topic as, is it the same as grown-up children? I think at my age, I think I would like to be called as a grown-up child. Over to you, Atul.
Thank you, sir. Good morning, everybody. I'm just sharing the slide. I hope it's visible.
Yes.
So we just start for all the students and other listeners with a very basic topic on how to assess a child's ECG, just understanding overview of all the nuances of pediatric ECG. So a pediatric age group extends actually right now we can consider from fetal itself, but when it comes to ECGs, it goes from neonate to infant to child and adolescent going to the young adult group. So placing the ECG leads with in an adult is usually a standard procedure. We all know about it, and these are the positions. However, in pediatric, we commonly use the right-sided leads as well. The V4, V3 are right on the right sides because of right ventricular dominance in small kids. And yes, so why do we use the right side lead? Because the right ventricle is a dominant ventricle in newborn, in younger infants, all the way till first year of life, and with particularly with these young babies, you should note that we try to keep the leads more proximally, or the limb leads more proximally, because if they are constantly moving, so we get more artifact if we keep them distally. So try to place the limb leads more proximally. Give the baby some distraction or some regular caregiver to reduce the anxiety and also reduce the artifact associated. Coming to why there is a different normal for the child. And we all know that the electrical activity of the heart, it reflects the hemodynamic changes occurring in the body. And as in the human body, the most changes occur from the first day till the first year of life, and it is applicable to every organ system. Similarly, the various changes occur in the heart, hence the different stages of the ECG occur. So there are different patterns. The one is the neonatal pattern, which is full of transitions from first week of life to first month to a first year of life. Then after that, we have the infant pattern, juvenile pattern, and finally the adult pattern. This is how the pediatric ECG evolves. From neonate, there is a different ECG for first 3 days versus different ECG for the first month, from 3 days to 30 days. Then as infant, child, and juvenile. It's also important to understand the fetal circulation and how the transition occurs after birth. The fetal circulation, the RV is the dominant ventricle, and it usually pumps into the high resistance pulmonary circuit, whereas the LV, the RV pumps to the systemic in fetus, but when the transition occurs, it starts pumping into a high resistance pulmonary circuit. The LV, as actually initially in the fetal life, is pumping into a low resistance placental circulation, and after birth changes to a high resistance systemic circulation. Thus, the RV, which is contributing 60% of the systemic circulation in a fetus, is now reduced to 30% in a high resistance circulation. So at birth, the RV to LV mass ratio is nearly 1, and which is why the neonatal pattern of the ECG is seen. So when you note a pattern, we see a depolarizing activity, which is denoted by the QRS complex, and a repolarizing activity, which is denoted by the T wave. And this is the relative thickness of the ventricles in newborn versus the adults. So what is a neonatal pattern? A neonatal pattern, you have the RS ratio in V1 positive and T wave positive till the third day of life. After 3 days, the T wave changes to biphasic, and by 1 week, it is already inverted. A persistence of a positive T wave in lead V1 after the first week of life is a marker for right ventricular hypertrophy or elevated pressures in the right ventricle, be it PAH or some other anomaly. And then usually when we report a ECG, we should look most importantly at the top left corner of the ECG strip, where the patient age is noted, and also then the lower left corner where the ECG speed and standardization are noted. After looking at that, we should we have a systematic way of following the rate, rhythm, axis, P wave, QRS complexes, the ST changes, and QT interval to be noted. We should be able to identify artifacts, and because it's very common in children to have that. And most importantly, we should use age appropriate reference values for all the intervals and the axis as per the age. So the P wave is usual. The normal P wave axis is between 0 to 90 degrees. There's usually with the adult and pediatric ECGs, not much difference in the P wave, but sometimes we find low atrial rhythms in sleep, and these sometimes are or in early neonatal period, we may find a ectopic pacemaker, which is competing with the sinus beat. And this is an example of a low atrial pacemaker where the inverted in lead 3 and AVF. And this is a usual P wave axis for the child. The PR interval is is usually between 80 milliseconds to 160 milliseconds in the young child, and generally it lengthens with age, and where we get the normal PR interval of up to 200 milliseconds in the adult. Short PR interval is also associated with WPW and other forms of pre-excitations. The QRS axis is determined by the dominant ventricle. In case of small children, it is the right ventricle which is the dominant. So at birth, right ventricle dominant, hence the axis is more rightward or inferior. As the LV mass grows, the axis gradually shifts leftward and becomes an adult pattern by approximately 1 year of age. This is an example of an extreme left axis deviation. And this is the example of the inferior or right axis. So yeah. So duration of a QRS in newborn, actually it's very short and very spiky. Only up to 2 small squares, so 80 milliseconds. In less than 4 years old, it is up to 90 milliseconds, and 4 to 16 approximately 100 to 110, and adolescents it between 110 to 120 milliseconds. So even in a newborn, even 100 milliseconds is actually wide complex. So we should be very watchful of the age of the child when we are looking and deciding between narrow complex and wide complex tachycardias. Any disruption of the propagation leads to prolongation of the QRS duration, leading to bundle branch block patterns. Again, most important is QTC, and because these children have a higher heart rate, it is equally important to note the RR interval and find the QTC. This is the method to do that, to put the tangent along the T wave and finding the point of the QTC. The normal QTC is the same for child and adult, but it is possible to have transient prolongation of QTC in the babies when they are born, and which normalizes in the next couple of weeks. However, prolonged QT intervals are not very uncommon, and we do find congenital log QT syndromes and other forms of channelopathies in children. Metabolic problems, even sepsis or any neurological issues, electrolyte abnormalities, which is common in newborns, also prolong the QTC and are important thing to note in especially preterm and term babies in the NICU. So presence of Q waves is interesting because Q waves are fairly normal in children, but however, they are narrow and short, and they are seen in the left side precordial leads and in lead AVF. Um, However, what are the pathological Q waves? Pathological Q waves are seen in either they are abnormally deep or abnormally deep and wide, and they are seen in either ventricular hypertrophy of the volume overload or with some form of myocardial infarction and things like Al-Kappa. So ECG in a neonate, we should note the following points. The axis is rightward. A dominant R wave is noted in leads V1 to V3. Q waves may be seen. Heart rate is generally high. Cardiac output is dependent on the heart rate and not on the stroke volume in kids. Shorter intervals are seen in terms of all the PR interval, the QRS duration, all the shorter as compared to adults. T-wave inversion is seen between the first week of life, and often sinus arrhythmia or some form of sinus ectopic atrial pacemaker is seen in sleep. So, but the thing to note is the newborn ECG is a normal newborn ECG actually is similar to the ECG of an adult with RVH. And this is the ECG of a less than 3-day-old baby. You can see that there is a dominant R wave V1. The axis is rightward. Lead 1 negative, lead AVL negative, AVF positive. You can see the sharp Q waves. The T wave is positive in lead V1, and RS ratio is positive in V1 to V3. After 3 days of age, the axis still remains the same. We can see the same spiky short Q waves. The RS ratio is still the same, but what is seen is the T wave, which was positive in the first on the first day, is now become sort of biphasic and tending to go negative in V1, V2, V3, while it's positive in the left side, left precordial leads. So in a newborn, after the first week, we can see that the T wave is now sort of more negative, coming to V2, V3 being positive biphasic, but we see the V4R now here, V3, V4R, and these are very dominant as compared to the left-sided V4. So suggesting that the right ventricle is still the dominant ventricle. So at 1 month of age, the T wave is clearly negative now in V1, whereas the RS ratio is still the same, V4 is still the same. So there is a transition of the repolarization pattern. As the newborn becomes an infant, between 1 month to 1 year of age, the axis starts looking leftward. As the left ventricle grows and becomes thicker, the axis starts moving leftward. The R waves in V1 to V3 start becoming smaller and shorter than the S waves. So RS ratio starts changing. Around 6 months, it is more or less equal, and then it starts changing towards the left ventricle. Q waves also start disappearing, and then T waves are seen mostly in a juvenile pattern, that is the V1 to V3 negative, V4 to V6 positive T wave. This is for a 4-month-old baby, and what was seen previously very tall R waves are seemingly shorter now, and taller V4, V5, V6 noted. Axis has also started to shift leftward. AVF is not strongly positive, but it is sort of biphasic now. So it is in the lower left quadrant. so lower right quadrant. Then as the baby is 2-year-old, again the RS ratio has now shifted. V1 is R in V1 is smaller than the S in V1, and there is axis is more in the usual quadrant. And late childhood or in adolescence, it is, see, axis is usually like a adult. The T wave inversions are seen, which are called as juvenile T wave, sometimes persist into early adulthood or the young adults. Sinus arrhythmia could still be seen into the adolescence. In adolescent children, sometimes they come with some chest pain and we do an ECG, or even if we do some school health screening, we very commonly find a benign early depolarization pattern. There is ST, sometimes ST elevation noted in those leads, or J point elevation, but they do not represent, or they are not very typical of any MI changes. These are the ST changes, and then the machine records as a abnormal ECG. So there are certain criteria for right ventricular and left ventricular hypertrophy, and the main thing being the right ventricular R wave in lead 1 is higher than the 98th percentile, and the percentile charts are that usually we follow are the Davinian charts. Um, so presence of right axis deviation, a higher RS ratio in the right precordial leads, sometimes upright T wave in lead V1, all are suggestive of right ventricular hypertrophy in children. And for the left ventricle, again, the presence of high R wave in lead V5, V6. We don't have that Sokolov criteria where the V1 plus V5 more than 35, rather follow the percentile charts and the RS ratio. And also if there is strain pattern, it suggests LVH. These are some charts. These are the charts and some normal values taken from those charts. So take home message for from the presentation is, you should know, as the there are progressive changes occurring in the pediatric ECG. So it's important to know the age and the physiological situation of the child. We tend to have higher heart rates in the babies. The right ventricle is the dominant ventricle. PVR is higher in neonates. Pulmonary vascular resistance at birth is higher. Hence, it affects the ECG in a certain way, which we described. The heart tends to be a bit more vertical than an adult, which is a bit horizontal. So that also changes the nature of the axis. Use percentile charts when needed. We also note that the Q waves are normal in a baby. The right axis is normal, and the QRS intervals and PR interval is shorter. So if you keep these things in mind, we able to assess what is a normal pediatric ECG. You can take a snapshot of this and it just summarizes the entire presentation in one. So thank you for your time and open for questions if any.
Yeah, thank you, Atul, for this comprehensive view of a normal ECG of a child and how the transition happens. Just couple of things wants to add. I don't know how many people in adults still use those bulbs for taking the ECG, but in pediatrics we never use, because in small babies the skin can get completely damaged.
Yeah.
Another thing, for the stickers, also for newborns and small infants, we do have very small stickers, and we don't use the adult stickers because then there will be a lot of overlap between the chambers. And the third thing is, it may be better that you know whether the heart is levocardic, mesocardic, or a dextrocardic while we placing the leads, because otherwise the interpretation can be difficult and different. So these are some of the technical issues we need to take into account when we start taking the ECGs.
Dr. Atul, if I can ask a question. Is absence of juvenile T wave pattern of issue? Do we need to? What is the prevalence of juvenile T wave pattern? Say in 100 patients between 10 and 18 years of age. Would it be seen in 100% of children?
I think so. Yeah, most of the
Yes.
more than 90% we'll definitely see. I have not seen um, I've not seen anybody not having these symptoms.
So if
Sujay,
it's
can you
not
repeat
there,
the
then
question?
we need to look into it a little more. We need to investigate, Dr. Snehal.
No, actually, because we do see on regular ECGs. In fact, many times we do get a ECG because before doing any non-cardiac surgeries of the baby and this juvenile T wave, we see almost in all the patients.
No,
Especially
so
when
if not there,
Not having.
then
I
do we
would
need
say
to look at
the
it,
key word is to
investigate?
interpret it in context.
yes, that
Pediatric
is
ECG should always be interpreted in a context. The way you would give a broad leeway to normalcy in an otherwise healthy adolescent child is very different from a child with congenital heart disease where you are looking for expected findings. This difference will make all the difference in dividing normal versus abnormal in children.
Suresh,
So I
sir.
think one of the things
Dr.
to
Suresh, in that context,
Yeah.
if we can put it like, should all the children have an ECG at the time of birth? Sometimes like long QT, Al-Kappa, etc. could be, life-saving in certain cases. As a part of a neonatal program, at least in advanced areas, whether we should recommend a pediatric ECG in every child?
Sadly, Dr. Nambudiri, I've been associated with screening programs in India and different countries. Nobody has bought that idea, even though I understand the logic of it. Shall I slightly modify it and say that at least the cardiologist and the pediatric cardiologist should take an ECG when a child comes to them?
But Suresh,
Can I, Snehal,
And
can I
also,
add something?
yes.
yeah, can I
Can
make a
I add
request?
something to Nambudiri's comment?
Yeah,
I think that, doing ECGs for everybody sometimes may create unnecessary panic because these automated QT measurements, especially in children whose heart rates are fast, produce a failure. And we often get these referrals from the neonatal or the pediatric ward. They take a ECG for some reason in fever. Oh, QT is prolonged. So doing for everybody, I think is a double-edged sword. But definitely, at least a child with syncope do a ECG. I mean, we've had children, we have 2, 3 children have died in the family. And then still they have not done a ECG in long QT. At least that should be done. My one comment was, I missed the initial part of the talk, but did you talk about the early repolarization pattern and how common it is in children? Was it covered?
no, but can I make a request that there is a lot of overlap between Atul's talk and mine? Can we postpone the discussion until I finish it?
Yeah, sure, Suresh.
Because much of it, I can't help overlapping.
Just one comment of Yash's question. Yash, patients who come with syncope, I think the only thing we always insist in our pediatric talks also is get a ECG. If you don't get an echo, is fine. Actually, it's not required, but ECG is must in a child with syncope. So that always we keep on insisting.
Also, madam, the patients referred for cardiac evaluation for query murmur or other things also. It's better to not only just do a echo but complete evaluation and also see the ECG in those.
Absolutely.
Rather.
Amit, any comment?
No, I think as Dr. Suresh Kumar said, let's have his talk now so that we can discuss comprehensively both the talks. Dr. Suresh Kumar, please start your presentation.
Yes, sir. Just a second of a gap. I will take this opportunity to introduce one of our guests, Dr. Chenny Sriram, Director of Pediatric Cardiac Electrophysiology, Michigan University. And at the end of the talk, we were encouraged to have a discussion with all of us. Welcome, Dr. Chenny. And then as Dr. Suresh Kumar finishes his talk, then we would be happy to have your insights and discussion as well.
Thank you for inviting me. It's a pleasure to be amongst all the panelists, and I'm really enjoying the discussion so far. So without further ado, I'll let the other speakers continue.
Thank you.
Now, can I actually start?
Please.
Thank you, moderators. Thank you, Atul, for having introduced the topic so well. that I can sort of get down to business of interpreting ECG in a child. And what I would envisage as the learning objective in this discussion would be to understand common variations from normal, which Atul has discussed, to recognize distinctive ECG patterns in common diseases, and to appreciate the role of ECG in modern day diagnosis of congenital heart disease. Understanding ECG complexes, Atul has discussed them in detail. So let me look at ECG abnormalities in children. You can look at it in different ways, maybe as what happens in structural heart disease, what happens in arrhythmias, electrolyte abnormalities, in channelopathies. Abnormalities you can also look at as affecting the individual component of the ECG, the P wave, the PR interval, the QRS complex, and abnormalities in specific diseases. I'll try to do a combination of this, and I would avoid arrhythmia because that's a separate discussion. Now, P wave, we said, has its shape altered by right atrial, left atrial, or biatrial enlargement. And the axis of the P wave may change according to the focus of impulse formation, which may be altered in congenital heart disease. The students are very familiar with changes of left atrial abnormality or left atrial enlargement, where the width of the P wave of 3 millimeter or more, P wave may be bifid, where you call it P mitral, and the terminal negativity of P in V1 are illustrative of left atrial enlargement. My point is to point out that these things occur in congenital mitral regurgitation or rheumatic mitral regurgitation, which still occurs in many parts of India. And importantly, in post-tricuspid left to right shunts like VSD or PDA. In mitral stenosis, certainly the left atrium is enlarged. And the right atrial abnormality reflected as a height increase of P wave, and best assessed in lead to 3 millimeter or more is right atrial enlargement. And the congenital conditions which would be associated with this would be severe valvular pulmonary stenosis, severe PAH, tricuspid atresia, Epstein's anomaly, tricuspid regurgitation, and older children or adults with tetralogy. Biatrial enlargement, when you have features of both left atrial and right atrial, a P wave amplitude exceeding 3 millimeter and the width exceeding 3 millimeter, or more often, as you would see in this ECG, there's a tall P in lead 2 and a deep negative deflection in V1, which is one division, more than one division in depth and duration. This particular ECG is of a child with restrictive cardiomyopathy who is scheduled for transplant. But conditions like congestive pericarditis, mitral valve disease with severe PAH, and Lutembacher syndrome can also produce such problems in congenital heart disease. Atul referred to an abnormal P wave axis. A retrograde activation of the atria, as in junctional rhythm, the P waves are inverted in leads 2, 3, and AVF. What we are referring to here more often is how the P wave is used to assess the atrial situs. In atrial situs solitus, the P waves are upright in lead 1 and inverted in AVR. And if they are the other way around, an upright P in AVR and an inverted P in lead 1, that suggests situs inversus. And an abnormal P axis, you may find without a situs problem, a little leftward P axis in sinus venosus ASD. In right isomerism, where there are two sinus nodes, you may find the ECG seeming to fluctuate between atrial solitus and atrial inversion. And in left isomerism, you would more likely have a low atrial rhythm, as was illustrated by Atul earlier on. So this is a situs inversus dextrocardia. Why would you say that from the ECG? Look at lead 1, the P is inverted, and in AVR, it is upright. And that shows atrial inversion. But when you look from V1 to V6, there is a progressive diminution of R wave voltage, which means the ECG is going away from the heart, dextrocardia. And the right side athletes confirm that point by showing large complexes. That is how, from ECG, we make a diagnosis of situs inversus dextrocardia. This is the low atrial rhythm that Atul referred to. Look at lead 2, lead 3, and AVF. They're all inverted and they're preceding the QRS. We used to call them coronary sinus rhythm in the past. This is a feature of left atrial isomerism. In left atrial isomerism, there is an agenesis or hypoplasia of the sinus node, and the zone of impulse formation is shifted caudally, and the impulse is forming from the low atria. This is a junctional rhythm where you find that the QRS is preceded by a P wave in 2-3 AVF, more often seen as either as a benign abnormality or as an arrhythmia. Sometimes, I earlier made the point that in congenital heart disease, ECG is always seen in context. This is the ECG of a 4-month-old baby, which was recently operated in my hospital. This baby had a large VST with heart failure. What is unusual is that there is a low atrial rhythm. Now, when we see low atrial rhythm, we think of left isomerism in congenital heart disease, but not necessarily. This child had an unusual condition. Just watch this video. I hope it moves. Otherwise, the image is seen here only. You can see that the central line put from the right subclavian vein is into the left superior vena cava. And the left superior vena cava is draining into the right atrium, like you would normally expect a left superior vena cava. But the point is, there is no right superior vena cava. An extremely uncommon anomaly, the absence of the right superior vena cava in this child, we recognized during further evaluation, was associated with the smallness of the right side structures. So this is absent RSVC, and the clue is a low atrial rhythm. PR interval, what happens when it is long, when it is short, Atul has already discussed. I would only point out that if the PR interval is longer in the context of a congenital heart disease, think of a familial secondum AST, any form of an AV canal defect, Epstein, or an acutely occurring event like a myocarditis, digitalis toxicity, etc. Short PR interval, we always think of WPW syndrome, but in children, also think of metabolic diseases like Pompe's disease or Duchenne muscular dystrophy. And not to forget that the PR segment could be depressed in pericarditis, and pericarditis is common enough in children as an acquired problem. Moving to the QRS complex, abnormalities in the QRS complex may denote either conduction disturbances or ventricular hypertrophy. And the delta wave clinches a diagnosis of WPW syndrome. The criteria for right ventricular hypertrophy were enunciated by Atul. I would point out that the criteria in smaller babies are defined by the centiles, but to have some rule of the thumb, in the first month, it fluctuates from 21 to 27 mm, the 98th centile. So an R more than 27 mm should be considered abnormal if it is associated with a heart disease. And by the time it is first year, you can bring down that the threshold to 10 mm. A very useful criterion is the upright T in V1. Atul pointed out that the T is inverted between day 3 and day 7. After day 7, an upright T is abnormal until the prepubertal age, or at least 7 years of age. So an upright T in V1 is a very sensitive criterion of right ventricular hypertrophy in children. R/S ratio in V1 more than 1 is very pointless in children, except in very old children, and always use this in context. A QR pattern in lead V1, it's not lead 1, it's V1, is far more reliable. And if you have an RSR in V1, with the R primum taller than 15 millimeter in the first year, or more than 10 millimeter in the first year, or more than the 98th centile if you want to be accurate, That is suggestive of right ventricular hypertrophy. Right ventricular hypertrophy, and I was pointing out that Atul has already shown the criteria for it and suggested the importance of using the 90th centile rather than an absolute value. But we older people like to have a rule of thumb, and therefore in the first month, something exceeding 21 mm, closer to 27 mm near day 1, and after first year, something more than 10 mm is reasonably suggestive of RVH in a context. The upright T in V1 after 7 days of age is a reliable sign, is a sensitive sign of right ventricular hypertrophy. The R by S ratio, as we use in adults, is not that reliable. A QR in V1 is, and if there is an RSR, the height of the R primum, if it's more than 15 millimeter in the first year of life and more than 10 millimeter above the first year of life, that is useful. And a right axis deviation above 120 degree above 1 year of age, closer to newborn period, it should be much more to conclude that there is right ventricular hypertrophy. And the ventricular activation time more than 30 milliseconds is also suggestive of RVH. Now, once there is RVH, we like to know whether it's related to pressure overload or a volume overload. The tall R in V1, V2 with ST depression and T inversion, it's strongly suggestive of pressure overload. And about 2 years of age, this ratio of multiplying the R height in millimeter into 5 to calculate the RV systolic pressure is fairly all right. Right axis deviation and clockwise rotation will go with it. But remember, when you interpret RVH with pressure overload, this particular ECG actually belongs to a TAPVC baby with suprasystemic RV pressures. So there is a complexity of lesion, the complexity of hemodynamics, and the dominant effect on the RV is the high RV pressure, which shows the ECG changes. The volume overload for RV is illustrated by incomplete or complete right ventral branch block as seen in ASD or AV canal defect. You can see the V1 where you find the RSR and the axis to the right. Left ventricular hypertrophy, Atul already pointed out that the typical Sokolov criteria are not reliable and small babies. Of course, in older children, if you find them, you may add significance to it. But remember that in a thin-chested older child, voltage criteria for LVH, particularly an R of 25 millimeter in lead 1 AVL or V5, V6 are not uncommon. When you are looking for LVH in small babies, the voltage criteria modified for the 90th centile for age could be applied. That is, an RV6 or V1, again, if you want a rule of thumb, in the first month, if it's more than 20 millimeter, RV6 or SV1, more than 20 millimeter, or by 6 months, 18 millimeter, or by 1 year, 21 millimeter, these values are sort of to remember before you look up the centiles criteria. An adult transition pattern is very suggestive. And T inversion inferior and lateral leads and left axis deviation, if there is no reason for left anterior hemiblock, are useful pointers. This is a child with LVH and pressure overload, severe aortic stenosis. You do not find the voltage criteria as you would expect in adults satisfied, but the AVL you will find is quite tall. But the important point is the deep T inversion in the chest leads. And volume overload, here, this is a 14-year-old child with severe mitral regurgitation. The LVH voltage criteria is not satisfied the way you would apply Sokolov criteria, but there is a deep Q in V5, V6. And there is evidence of left atrial enlargement because of the terminal negativity of P in V1. Biventricular hypertrophy, most commonly seen in infants with a large VSD or a complete AV canal defect or a truncus arteriosus, you would look for large equiphasic complexes in mid-precordial leads where the combined voltage is more than 4 to 5 millimeter, which is called the Katz-Wachtel phenomenon. If you find a combination of both, an LVH, but the axis is right, LVH with clockwise rotation, LVH, but there is a tall R in V1 satisfying to your criteria for 98th centile. These are circumstances when you may think of biventricular hypertrophy also. This is a complete AV canal defect. I apologize for the poor quality. I hope you can make out the RSR with the second R that is quite tall, the right upper quadrant QRS axis. Bundle branch block, classical RBBB, and left bundle branch block, you're all familiar with. But are you likely to see this in children? Yes. You may see it in ASD. You may see it in Epstein's anomaly. Following a VSD or tautology repair, you may see this. A left bundle branch block is uncommon in children, but you may see it after an LVOT resection. This is a typical WPW syndrome. I'll not deal with it in any detail. You can see the short PR interval and the negative delta wave in V1. The features of the ST segment and T wave have also been dealt with. Remember, the commonest cause for ST elevation in significant ST elevation children is acute pericarditis. And the commonest setting in which pediatric cardiologists would see it is in the post-hoc child. Myocardial infarction can occur in children with Kawasaki disease. During COVID, we have seen myocardial infarction due to coronary occlusion in children. T wave is altered by long QT syndrome, electrolyte abnormalities, or severe ventricular hypertrophy. This is the pericarditis. Why would we say this is not myocardial infarction and pericarditis? Look at the diffuse nature of the ST elevation. The diffuse nature of the ST elevation, and if you see lead 2, you can note a little depression of the PR segment. So typical pericarditis. The QT segment, again, how to evaluate the QT interval, Atul has discussed and said that prolonged QT interval could be due to congenital long QT syndrome. QT interval more than 440 milliseconds is definitely prolonged. And in presence of long QT syndrome, the T can take very different morphologies like a wide-based T wave, a bifid P wave, or a low amplitude T wave. These are all features of long QT syndrome. And this is one case where you can see that the QT interval is 600 millisecond and tossed in the same child. The common long QT syndrome features and the disease-associated gene are given here. I will not go into the detail other than to say that T-wave abnormalities could be characteristic in diagnosing the subtype of long QT syndrome. This is an ECG of ASD that we already referred to. You can see the incomplete RBBB. The axis is like a plus 90, normal sinus rhythm. But see here. Here, you can see that the axis is obviously left. Lead 1 and AVL are positive. There is an RBBB. So RBBB, left axis deviation, PR interval is normal here, but look for its prolongation. This combination is a feature of ostium primum ASD. And on a broader plane, when you are evaluating an ASD, ECG can give you a clue as to where is the location of the ECG. The secondem ECG has an upright P in 2,3 AVF. QRS axis is right axis. You have an RSR. Primum, same, but QRS axis is left and a PR interval could be prolonged. And sinus venosus, somewhat leftward QRS axis, leftward P axis and right axis deviation. In single atrium, which is a feature of left isomerism, which is common in left isomerism, you tend to get a low atrial rhythm and hence an inverted P in 2,3 AVF. And in single atrium, it can be considered a form of AV canal defect. So the axis is left. QRS in V1 is RSR. Epstein's anomaly, we speak a lot about. These illustrate two different cases. You can see that the QRS is wide and polyphasic in the illustration on the this side, while RA enlargement is present very prominently in the first one. In India, we tend to call very large A waves as Himalayan P waves, very large P waves as Himalayan P waves. First degree AV block, you can see in the second strip. WPW syndrome may be associated, and an arrhythmia may be the first presenting feature of Epstein's anomaly, as many of you would have seen. Tricuspid atresia, note that the axis is left. There is no initial R in V4R or in V1. The initial R that you would expect in a small baby is missing. So this is a feature of tricuspid atresia. Absent R waves in V1 and left axis deviation. Plus minus RA enlargement. Severe valva PS, same ECG as I showed earlier, could be seen where there is an RA enlargement, a tall R in V1 with ST depression and T inversion. Remember the formula for calculating the RV systolic pressure, right axis deviation and clockwise rotation. Tetralogy of Fallot typically has RVH with sudden transition from V1 to V2. Right axis deviation, RA enlargement may be seen in older children and adults. In repaired tetralogy, a complete RBBB with a QRS duration as a predictor of future events and prognosis is common. This ECG shows left axis deviation. You would more commonly see a right axis deviation. We will look critically at the PR interval, and we will look critically for arrhythmias in older children and adults with repaired tetralogy. Transposition, the ECG is likely to look like normal in a newborn, but if you find extreme right axis deviation, some RA enlargement, LA enlargement if there is a large PDA or VSD, and right axis deviation again if there is pulmonary stenosis or pulmonary hypertension could be seen, but by and large, ECG is not very contributory in TGA. Not so if it is a congenitally corrected TGA. What happens in congenitally corrected TGA? There is an atrioventricular discordance. The atria are connected to the wrong ventricles, and the ventricles are connected to the wrong great vessels. So the normal septal activation is altered. The normal septal activation is left to right, and that is responsible for the initial R in V1, and more importantly, the initial Q in V5, V6. You can see that here, the V1 has a Q wave here in V4R, initial Q wave, and the V5, V6 does not have the initial Q wave. So the absence of septal Q in left-sided leads is a very suggestive feature for congenitally corrected transposition. Axis is left here. Varying degrees of AV block are common in this, and in this particular case, it's a complete heart block. Alcapa, anomalous origin of the left coronary artery from the pulmonary artery, is a common enough problem in pediatric cardiology practice. A child who is presenting with severe congestive heart failure, generally short duration, if it's coming at 2 months or 3 months, where you might think of myocarditis, but the ECG shows that there is a deep Q in lead 1 AVL and V5, V6. This ECG also shows an ST elevation, not that common in L-kappa, but this combination is almost pathognomonic of this diagnosis in an infant in CHF. Truncus arteriosus, again at birth may look normal, but slightly older. The abnormal axis and the biventricular hypertrophy, in this case, tall R in V1 and also a tall R in V6. That would be the giveaway of evidence of biventricular hypertrophy in this context, truncus arteriosus. Congenital complete heart block is being discussed today, so I won't discuss it other than to say that when you see a child with bradycardia in the ECG, always look for heart block. You are looking for more P waves than QRS complexes, and the heart block in a child could be autoimmune or maybe associated with a congenital heart disease or post-op. And trust me, your knowledge of adult cardiology and adult ECGs can come to your help. Look at this ECG. This was relayed to me from an ambulance which was transporting a 2-day-old baby, saying that we have a baby with this ECG. The question that I asked was, are the pulses palpable? They said yes. And then we got the reason. When the baby was admitted to NICU, the baby had a serum potassium of 8 milliequivalents. And once potassium was corrected, we got a decent ECG. So atrial paralysis, sinoventricular conduction with tall T waves, something that you more often see in a chronic renal failure patient in adulthood, may also present as a bizarre problem in children. So what is the role of ECG in congenital heart disease? It should be interpreted along with clinical X-ray and echo findings. And you must recheck clinical and echo findings if not consistent with your ECG. Best example, you have diagnosed viral myocarditis, you have seen the echo, but you have not seen the coronary. The ECG suggests L kappa. Very likely your echo is wrong. You have missed the abnormal coronary. And ECG provides both anatomic and hemodynamic information, and used intelligently can contribute to decision making and management. Thank you very much. Sorry for the confusion. And these are some of the references for the values that you may like. Thank you.
Thank you, Dr. Suresh Kumar, and that was a good presentation by both the speakers. I'll just make a brief overview of my, about pediatric ECG. One of the things which needs to be remembered is that in terms of the rhythm, sinus arrhythmia is very common in children. AV Wenckebach and Mobitz type 1 block is often present in up to 10% of the people. So it should not be mistaken, because often we get a reference for a relative irregularity of the pulse and a dropped P wave more often at night time in a Holter, suggesting that whether pacemaker is required. So that is also physiological in many of the children. Few things which Yash touched upon, and I think I will elaborate now, is that the question of prolonged QT interval in the neonate. So I think neonatal ECGs are very important to be interpreted appropriately. If you take a neonatal ECG, you might find a long QT than what is expected. What often we say is eyeballing. If the QT interval is more than 50% of the RR interval, it must be a prolonged QT, and then you can measure in details. But this is often seen in neonates. It will take almost 1 month for the QT to start normalizing. So after 1 month, QT interval interpretation becomes more appropriate. So you need to look at the clinical setting. The other thing which Yash wanted to pick up was about the benign early repolarization. So early repolarization is a very common finding. Almost 1 to 2% of the population will have early repolarization. And often it's a confusing thing when, now we have malignant early repolarization syndromes and sudden cardiac deaths, and we start wondering. So a brief about early repolarization is that if you have a concave upward ST elevation limited to the precordial leads, more often than not, this is an early repolarization. And then we look at the ST segment to T wave ratio. If the ST segment elevation is less than 25% of the amplitude of the T wave, it is confirmed that this is a benign early repolarization change. So the malignant ones are to be identified if you start seeing the ST elevation in inferior leads. If you see a convexity in your ST elevation, then you start thinking in terms of a malignant early repolarization. And those are the ones which are associated with syncope and family history of sudden death. The last comment is about what Ajay brought out earlier in terms of the persistence of the juvenile T wave inversion. In terms of juvenile T wave inversion, I think what we need to understand is that when the T wave inversion in the precordial lead continues beyond the young children in 8, 10, 12, 14 years of age, we call it a persistent juvenile pattern. And this persistent juvenile pattern of T inversion beyond 8, 10, 12 years is also physiologic in quite a few number of people. It is just that the T wave inversion tends to start normalizing after the first year of age. Up to 7 to 8 years, most children will have a normalization of the T wave. In the very first year of life, if instead of a T inversion, if you have a T upright in the precordial leads, yes, that should raise your suspicion about a underlying congenital heart disease. I think we had a good session, and we have the international expert here who can give us some comments, feedback.
Yes, thank you. Is there anything particularly that you wanted me to talk about?
No, I think based on the talks which you heard, did you have any particular comments to make?
Yes, I think there's the first thing, as we all sort of agree on, is that there's a lot of variation in the pediatric ECG, and it should be interpreted in the right context. Couple of things that I would say, and again, it's already been emphasized in the talks already. Anytime you see a T wave inversion in the lateral precordial leads V5, V6, that's always abnormal, no matter what. So you should not expect to see a T wave inversion even in a baby or a child. So that's really abnormal. The second thing is that the duration of the QRS. I can tell you how many times people have diagnosed narrow complex tachycardias with QRS of being 80 milliseconds or so. Once you have a QRS around 80 plus milliseconds, that in a baby becomes a wide complex tachycardia. Although it can always be an SVT with an aberrancy, once in a while you'll be dealing with ventricular tachycardia. The ventricular tachycardias of that age group can be QRS of 80 milliseconds, looks narrow to the adult trained cardiologist's eye, but for the pediatric trained cardiologist, it should be focused on that. We do see vesicular VTs, look for AV dissociation and things like that. Make sure that you don't miss a VT in a pediatric population, although it's going to be rare. Third thing about these juvenile T waves, the juvenile T waves always follow the normal T wave pattern, whereas the normal T wave is always going to be asymmetric. Abnormal T wave is going to follow the opposite pattern. The normal T wave being asymmetric, meaning that the slope of the upslope is always less steeper than the downslope. That's going to be maintained in a juvenile T wave. Whereas when you see the opposite pattern, whereas the downslope is more steeper, upslope is more steeper than the downslope, or it's completely symmetrical, then you have to interpret that with more caution. Again, there's a lot of age variation. Where I work, you see juvenile T wave patterns in African Americans even up to 21 years of age. So there's a lot of variation depending on ethnicity. The white Caucasians, it's less common. So there's a lot of variation that has to be interpreted in. You have to interpret that in that context.
Thanks, Dr. Sriram, for those inputs. Dr. Suresh Kumar, there are quite a few questions on the chat box, and if you can, the questions are in terms of clockwise, counterclockwise rotation and looping of the ventricles. How do you interpret ECG in that context?
The simple answer, you look at where the Q is in lead 1 and AVL and in 2-3 AVF. If you have a Q in lead 1 AVL, the loop is counterclockwise. And if the Q is in 2-3 AVF, the loop is clockwise. I think for an elementary teaching, I would go by this rule of thumb.
And in terms of the looping of the ventricles, does the looping of the ventricles follow the clockwise, counterclockwise rotation?
No. When we say, now here we must understand what we mean by the looping of the ventricles. When a pediatric cardiologist refers to looping of the ventricle, he is referring to a D versus L ventricular looping, whether the anatomic right ventricle is on the right side or on the left side. I discussed the ECG findings of congenitally corrected transposition where there is a ventricular inversion. Now, the normally looped ventricles, the D loop, the ventricular septal activation will be from left to right. And therefore, your initial Q in V5, V6, a very important normal finding. The absence of that suggests that the ventricular septal activation has been altered. And one of the reasons for that alteration is an altered looping, an L ventricular loop. There any other?
Thank you.
That I can take?
Thank you. I think that covers most of it, and we probably are a little short of time. Any comments by Ajay or Snail, or should we move to the next session?
I think we can move on to the next session. I'm sure in the cases, more discussion will come up.
Sure.
You must pardon me for signing off. I have another commitment. Thank you very much.
Thank you, Dr. Suresh Kumar. I think moving on to the next session, we have interesting case-based pediatric arrhythmias to be discussed, and the first is approach to neonatal congenital heart block by Dr. Ronak Sheth from Fortis Hospital. Over to you, Ronak.
Hello, good morning. Thank you for the opportunity. Is my voice audible?
Yeah, you're audible and your slides are seen. You can go into the uh, mode of, yeah, thank you.
Okay. So today I'm going to talk about neonatal complete heart block. We'll be, sorry, they are not moving. Okay. Yeah, so we'll be going through the clinical scenario, and then we'll be briefly touching upon the definition, classification, and pathogenesis, and then a brief approach to management. So first scenario is primary gravida mother has been detected to have a slow and irregular fetal heart rate in the 25th week of gestation. So initially this heart rate was around 65 to 75 per minute with an atrial rate of around 140 to 150. Also, the fetal echocardiographic examination wise is remarkable for a cardiothoracic ratio of 0.59 and a cardiothoracic area ratio of 0.39, both of which are mildly elevated. A detailed family history and a pedigree charting of this case revealed that two more cousins in the extended family required pacemakers in infancy. And maternal workup was done, and which was negative for autoantibodies. By 30th week of gestation, the fetal heart rate was further down. It was around 45 to 50 per minute. There was the fetus was starting to develop some degree of AV valve regurgitation. Although there was no effusion, no hydrops, and the fetal growth parameters were preserved. So this is the scenario which we commonly see in fetal echocardiography, where we are following these the fetus who has been detected to have a slower or irregularly slow heart rate. Most of the evaluation is done, much of the evaluation for such a rhythm is done by M modes across the atrioventricular walls. And so here we are seeing a regular atrial rhythm with a rate of around 145, and a ventricular rate, which is seen here, is around 41, 42. And the umbilical artery Doppler also gives a slow heart rate of around 35. So we have to follow these babies closely and follow the parameters of fetal cardiothoracic ratio, development of hydrops, and fetal well-being. So on close follow-up, this there was we had a neonatology team on standby, and the pediatric cardiac surgical and ICU team were also alerted that, with the baby developing a very low heart rate and starting to develop some AV valve regurgitation, there may be a need for an emergent delivery and strong neonatal support. Maternal terbutaline therapy was discontinued after a short period as it was not tolerated well. Luckily, this baby could be stretched out till 37 weeks and was delivered at full term. So that was a good part of it. However, another revelation which came later was that this baby was starting to develop significant ventricular dysfunction. So this is the echocardiogram as in the initial few hours after the baby was born. And this is the ECG, which is showing complete AV dissociation and regular atrial rate of around 150 and a very poor ventricular escape rhythm with a heart rate of merely around 50 with some broad QRS escape rhythms as well. So baby underwent an epicardial pacemaker implantation. Heart failure therapy was optimized, and within the first few days, it was stable compensated heart failure on a small dose of diuretic and afterload reduction. At 1 month follow-up, this baby was continuing to have moderate ventricular dysfunction. Another case scenario is a baby who has been again detected to have a slow and irregular fetal heart rate in the 25th week of gestation. In this case, a maternal workup was done, and this mother was found to be positive for anti-Rho SSA and SSB antibodies. Also, maternal detailed evaluation, medical evaluation revealed mother having a left bundle branch block on her ECG, as well as mild LV systolic dysfunction. Although the mother did not have any symptoms or any prior hospitalizations or illnesses. So this was the initial scenario where the fetal heart rate was lower, around 70 per minute, with a preserved ventricular rate. However, on close monitoring in the fetal period, we were seeing a wide variation in the fetal heart rate from around 60 to 120 per minute. And in this scenario of a autoantibody positive mother, there is a risk of, so this is a high likelihood that this will, so this is the M mode showing a regular atrial rate of around 145, and this is the ventricular rate. We are seeing some clustering of the ventricular beats and drop in between. So possibly we thought that this could be a second degree heart block. So these were the two clinical scenarios. This baby is yet to be born, the second one. So what are we dealing with? So when we deal with AV nodal block in early life, there are two clinical distinct entities that we now have, we know now, and one is congenital complete heart block, which is diagnosed in utero or within the first month of life, and the second group is a childhood onset or a onset which is heart block which is identified after 1 month of age. So today we'll be focusing more on the congenital complete heart block. Depending on what all subsets are included right from the fetal period, there is a proportion of almost around 50% of it is associated with associated congenital heart defects like left isomerism and congenital corrected transposition. Many of these are seen in early fetal period, and many of them do not have a good outcome, and they do not see like they get terminated, or they do not continue the pregnancy. So majority of the scenarios where we are diagnosing congenital complete heart block within the first month of life in clinical practice are the subgroup which is autoantibody positive, where the maternal evaluation has revealed autoantibodies, anti-Rho and anti-La antibodies, and a small subgroup is non-antibody associated with a structurally normal heart. So this subgroup falls into it can be a myocarditis subset, or there may be a genetic familial condition or a cardiomyopathy. So etiology of neonatal complete heart block, majority of it is neonatal lupus, or what we call as passively acquired autoimmunity through maternal antibodies. Other lesser common aspects are structural heart defects, channelopathies. So what all is included in this term, which we say as immune mediated neonatal complete AV block, is when we are diagnosing CHB in utero or within the first month of life. It is an immunologically mediated fetal cardiac conduction system insult due to the transplacental passage of maternal autoantibodies. And gold standard of diagnosis is still fetal echocardiography in the fetal period. Most of these are now being diagnosed in the fetal period itself. So this clinical scenario is at the junction of multiple subfields of medicine, and managing these requires a close coordination amongst multiple specialties to ensure a good and safe outcome for these babies. So it is rare. It is only 1 in 15 to 22,000 live births. There may be associated CHD in a small percentage. However, there is a high morbidity and mortality risk, although in the recent years, this morbidity and mortality risk is slowly reducing. In studies, they have found that a fetal or a early neonatal diagnosis of congenital heart block increases mortality risk almost up to 20 to 30%, as compared to children or babies in whom the CHB is diagnosed later. So what is the incidence? Maternal antibody positivity is around 0.44% in the general population of 20 to 50-year-old females. Only half of these females will go on to develop an autoimmune disorder. The signature cardiac lesion is AV block. And in this population of maternal antibody positive population, there is a 2% risk of autoimmune congenital heart block. There is a 20% of these babies who have a cardiac affection will also have a component of cardiomyopathy. And maternal disease status is independent of the fetal outcome. And also there is a threshold level of anti-Rho antibodies, which is more than 50 units per ml, that is associated with fetal and neonatal disease. However, there is a no consistency in the dose response relationship beyond this level. A previous unaffected child does not decrease the risk. However, if there is a previous occurrence, then the recurrence risk is 20% for a recurrence of heart block or neonatal lupus and neonatal cardiac involvement in the subsequent pregnancy. Higher antibody titers do not correlate with higher severity of the disease, and additional anti-LAR antibodies may increase the risk. In addition to the anti-Rho antibodies, which give a risk of 2%, with anti-La additional, it may go up to as much as 5%. And third and subsequent recurrence risk is almost up to 50%. Severity of disease in the first affected baby and the sex of the fetus or neonate does not predict subsequent pregnancy outcomes. The alarming thing about this disease is the rapid progression and the irreversibility of this disease. So life-threatening heart block and cardiomyopathy may develop within 1 to 2 weeks of us having seen the fetus with a normal rhythm and normal function. So what is the pathogenesis of this disease? There are Rho-La antigens, which are intracellular ribonucleoproteins. During the course of fetal heart development, there is physiologic apoptosis, and these Rho and La antigens translocate to the cell surface. These antibodies, which are there in the maternal bloodstream, they have a transplacental passage mediated by FcRn receptors. And once they are in the fetal circulation, they bind to these sites on the developing fetal cardiomyocytes. They inhibit efferocytosis. Efferocytosis is the physiological removal of apoptotic cells during development. So this gets inhibited, and the pathological pathway of removing these apoptotic cells by macrophages sets in, and this sets off an inflammatory cascade with TGF beta and TNF alpha. This leads to AV node injury and fibrosis. So this is the placental barrier. FcRn receptors, they translocate the anti-Rho antibodies into the fetal circulation, where they are binding to all these cardiomyocytes, where the Rho and La antigens are present on the cell surface. Efferocytosis is inhibited and the macrophage pathway takes predominance. Once the macrophage pathway is kicked in, it gives rise to multiple inflammatory mediators, which then give rise to progressive fibrosis. There is another hypothesis. There are actually, because a single hypothesis is not sufficient to explain the entire pathogenesis of this disease. So another hypothesis is calcium channel blockade mediated. So it is believed that these anti-Rho antibodies have a direct inhibition of L-type and T-type calcium channels, and it inhibits the calcium currents, and accordingly through that pathway leads to an inflammatory response. Another theory is about microchimerism, where there are maternal cells with CD45 expression which are found, and so that is another hypothesis. So multiple hypotheses, because it is a complex pathogenesis, and despite much research, we still know very less about it. So the antibody is a prerequisite, but it is not sufficient for the development of the complete heart block, because there are it is found that there is additional fetal susceptibility factor and an additional environmental amplifying factor components are essential to explain why this happens like that, because only 2% of all the fetuses get affected. However, others on the other edge, when we see there are identical twins who are more often discordant for the complete heart block, and so possibly a hypoxia related CAMP pathway differentiation of fibroblast is proposed, and there is some work going on biomarkers to explain the pathogenesis of this disease. And
I
this is
think we have
something.
another 2 to 3 minutes, isn't it?
Okay.
Angudri?
Okay, going to management. So I'll just briefly go to the management. The 16 to 28 week period is the most vulnerable period where the antibodies have crossed into the fetal circulation, and the fetus is at a high risk of developing this complete heart block. So this is the scenario, this is the period, the mid trimester, in which we need to have a close review of the fetal parameters. So multiple agents have been tried in these pregnant mothers. The only ones with some trials and some hard data to support their use is one is hydroxychloroquine, which inhibits toll-like receptors and reduces plasma interferon levels and reduces the pro-inflammatory state in this scenario. And other is fluorinated steroids, that is dexamethasone and betamethasone. They are used in the mother, they pass across the placenta and is bioavailable in the fetus. This is the monitoring of the mechanical PR interval that we do in the pregnancy to look at prolongation of this PR interval in the fetus, which would be a first sign of AV nodal injury in the developing fetus. There are some high risk antenatal factors like development of fetal hydrops, low fetal heart rate less than 55, associated congenital heart defect, associated heterotaxy, LV endocardial fibroelastosis, delivery less than 32 weeks, and presence of ventricular dysfunction or cardiomyopathy. Postnatally, if there is a significant bradycardia, emergent management with inotropes may be required, and temporary cardiac pacing may also need to be instituted. Permanent pacing is necessary in about 80% of these scenarios in early life. So for pacing, permanent pacing, several criteria are considered to determine the need for pacing. One is average heart rate, duration of pause in the intrinsic rhythm, QRS escape rhythm duration, and prolongation of QR. So the recommendations for pacing in a congenital complete heart block: if there is a complete heart block along with symptomatic bradycardia or low cardiac output state, if the rhythm is a wide QRS escape rhythm, or there is complex ventricular ectopy, or there is ventricular dysfunction, these are all class 1 indications for putting in a pacemaker. Infants with a normal anatomy with a ventricular rate less than 55, and those with a structural congenital heart defect with a rate less than 70, these are all class 1 indications. Pacing in neonates is always technically challenging. Small size of the baby with the rapid growth, and this usually the pulse generator is implanted in the abdominal wall. In less than 2.5 kg weight, the generator may be placed in the pleural cavity. Most of the times, LV apical or lateral wall pacing is recommended because it is proposed to better preserve LV function. There is no significant difference in the VVI and DDD pacing modalities in terms of quality of life or cardiac function. There is an incidence of pacing-induced ventricular dysfunction, cardiomyopathy in around 7%, definitely, but many studies claim up to 25% also. There are some complications of permanent pacing, epicardial pacing in these babies, lead fractures, lead insulation breaks, and loss of capture. Okay, and finally, future prospects which are on the horizon are gene therapy for biological pacing in these smaller babies, inhibition of molecular inflammatory pathways for preventing the complete heart block, genetic polymorphism detection to predict which babies are going to develop this conduction system damage, and fetal biomarkers for predicting the severity of disease in a particular fetus. Thank you.
Thank you, Ronak, for that in-depth analysis of two good cases of yours. Let's open this. Dr. Namudri, you have any comments to make?
Yeah, it's a very important area. In fact, if you look at the series, I mean, the recommendations, including the PACES 2021, the recommendations are mainly focused on pacing beyond infancy. When the child comes in the neonatal phase with complete heart block, the recommendation for pacing is very complex. It is not, but it's basically based upon the hemodynamic factors and tiding over the crisis. Many times, if you tide over the crisis and the neonates grow up into infancy, and the need for pacing would be minimal, or maybe it can be planned later. Generally, what we do, beyond what Dr. Rotak mentioned, is to consider tissue hypoperfusion and serum lactate levels in the ICU. If the lactate level goes up, we take this patient for an early pacing. And if the child is very small, there is an additional modality. You can do an epicardial wire pacing so that you don't have to put a PG in the rectus sheath or a pleural cavity, which is definitely more difficult, and tide over the crisis over a period of 1 to 2 months. Generally, these patients will have associated hypocalcemia, hypothermia, and other sepsis and other factors, especially in neonatal phase, which can contribute to the hemodynamic problems. This is one important factor. Another thing is that this antibody titer levels and all, it's more commonly based on the description by that Mayo series and others. In India, the antibody related CHB, somehow it is not that very high. Not more than, definitely more than 5% of, it's mentioned that antibody negative occurs in 5% or something like that. Here, nearly 50% of more are antibody negative. If you take SSA, SSB, both of them, either of them. So these 2 points I would like to mention. And we generally do this wire pacing nowadays because of the problems associated with keeping a PG in the rectus sheath, which can have problem. And suture leads are extremely useful in these cases. Bipolar suture leads compared to screw-in leads. That in the last, we have done in less than 28 days, 20 cases had undergone pacing in the last 10 years, and we had lead failure only in 1. So this wire pacing and suture leads would help to tide over a crisis a lot.
Again, a couple of comments. One, Amit, because this is a very common thing which we deal in pediatric practice, because most of the anomaly scan, the obstetricians or or fetal medicine people can diagnose that there is a heart rate abnormality. And this is one of the very common indication for a fetal echo in pediatric cardiology practice. We have to check this PR interval because that is one of the precursor of development of complete heart blocks. That is one of the things. So once we see these intervals and there is a prolonged PR interval, there is a possibility that they'll develop complete heart block. That is one thing. Second thing, we can give steroids or immunomodulator, but if that is detected in like maybe before second trimester, once it is set in, then we can't do anything. So this monitoring the intervals is very important. And second thing, we have to keep on checking the evidence of hydrops on fetal echo, because that is the indication you may have to deliver the baby orally. Once the hydrops develops and ventricular dysfunction starts, the mortality or even the rate of stillbirth becomes very high. And the third thing what Dr. Nambudri said, we also had done this and published also, because we have some premature babies weighing some 1.2, 1.3 kgs, where putting a permanent pacemaker was technically difficult for surgeon, and we do put this epicardial small wires, kept the babies for a month or so. Then the weight became around 1.8 to 2. Then we went ahead with a permanent pacemaker in these babies.
So there are a couple of questions in the chat box which I think we should take. So for Ronak and Nambudri both, is there a role of temporary pacing through the umbilical vein? Any experience with that?
I don't know. We haven't done it, but I don't know whether it is a possibility.
Correct. So I think this is not something which I've also heard or done.
I don't know.
Child will be
right.
neonate will be highly irritable, and it's very difficult to keep the position intact. And with bradycardia and hemodynamic problems, of course, hemodynamic problems only demand. It sometimes it can induce a lot of ventricular arrhythmias as well.
And
But
secondly, the RV cavity is so small in these babies,
yeah.
Even positioning the catheter in that particular thing is maybe difficult. But
Another question is that what is the current status of fetal ECG?
no,
Have
no,
you reached any stage where a fetal ECG
no.
can be?
We
No,
also have tried a lot, but it's not possible yet. But I think
only
M4
fetal
M4
magnetocardiograms are being done in research centers in the Western world, and ECGs are still far away from reality for the fetus.
So the Ronak's first case had LV dysfunction, and in a neonate, obviously epicardial pacing, single chamber pacing is what you do. But Nambudri, with LV dysfunction, would you at all think that a dual chamber pacing should be attempted? Would it be worthwhile, or it's difficult?
Sir, dual chamber probably will not help in LV. Probably the question was on CRT, I think. He had tried CRT in maybe like a 2 to 3 years after having had a pacemaker already, and pacemaker related ventricular dysfunction cases. We have tried CRT upgradation. In some cases with a structural heart disease as well, but results are always suboptimal. And another point regarding that umbilical cord, generally umbilical entry will lead on to through the IVC to interatrial septum to left atrium. Getting into the RV, it's sometimes difficult to put a lead from IVC route.
Dr. Namudiri, the question about epicardial wire, this is the surgical epicardial wire which they put after surgery, which is extruded and kept outside.
Sir. We can just put a subscaphoid incision, get into the RV and keep a wire there, and the suture, I mean, like post-operative epicardial wires, the same wire can
but
be.
But doesn't the threshold go up in a few days? How do you manage that?
It is generally a very simple procedure otherwise, and in a small kid it is very helpful. Even if it goes after 10 to 15 days, it doesn't matter really. We can even repeat the work, or by that time we will have a solution.
Yeah.
I think we should move to the next presentation, and that is refractory supraventricular tachycardia in a young child. And Dr. Kishore, are you ready to share your presentation?
Sir, one more thing about the pacemaker in the complete heart block in the infant, we should also look for long QT. You should not forget that. Apart from the other causes, which also may need a pacing, if it's like a prolonged QT, where the pre-wave is not getting.
Very important point, because in fetal echo, if you see a 2 to 1 AV block, we don't know it is an evolving CHB or it is related to long QT, because therapy is very, very different. One case you need to give beta blockers, in other case we have to avoid that and give this terbutaline. Like we had encountered this problem, and someday we will present that interesting case, because the management is quite difficult, and there are some echo markers that can predict whether it is 2 to 1 AV block related to long QT or it is related to pure CHP. It's an interesting area. We'll present one day.
Yes, Dr. Kishore, please be mindful of the time. Go ahead, please.
Yes, sir. Good morning, everyone, to my panelists and the audience. So today I'll be discussing regarding refractory SVTs, and the discussion will go based on the case scenarios. So this is a first child, born 37 weeker, 3 kgs, a female one. She came to us when she was 5 days old. She had a history of fetal SVT. On after post delivery, there was no any features of heart failure, and on day 1 she had an episode of SVT which responded to adenosine.
You sure your slides are not seen? Only the first slide is, only the title slide is seen. You may go to the presentation view.
I'm in presentation view, sir. Like now, sir.
You have to share the presentation.
Yes.
Sir, is my slide seen, sir, now?
Yeah. Go to presentation mode.
Sir, the presentation mode. Now, sir?
No.
Somehow your click is not accepted. Click it again on the presentation mode.
Again, I have done presentation mode, sir.
No, doesn't matter. Just zoom in a little more and then you can continue presenting.
Okay, sir.
Zoom out a bit.
100%.
Yeah, that should be okay.
Yes.
Yeah, go ahead.
Okay, so this is our first case who had she had SVT at birth, which was aborted with adenosine. But later, at 15 hours of life, she developed multifocal atrial tachycardia, for which she was given amiodarone infusion and she was referred to our hospital. She was on medication propranolol. On echo, she had a small PDA which closed at 5 days of life, and both bilateral function was good. So the ECG shows narrow complex tachycardia with regular, which is regular. P waves were not clearly visible. However, in lead 2, there were signs of long RP tachycardia. These were P waves probably, and she had long RP tachycardia. And so, with the in view of long RP tachycardia, we suspected her to have her atrial tachycardia. She was at admission. She was started on flecainide, and she was admitted to our ICU setup where sertraline was introduced, and ramidor infusion was continued. She, however, had continuous intermittent atrial tachycardias episodes in between, which were followed by this normal baseline sinus rhythm, which had a prolonged PR interval. So the antiarrhythmics were upped. She was later on put on amiodarone oral 15 mg BD along with flecainide, and the third antiarrhythmic was propranolol was introduced. Propranolol was introduced. All were done OD, and on day 9, with the continuing, despite of this three antiarrhythmics, her SVT was, her atrial tachycardia was not subsiding. So instead of propranolol, ivabradine was started, which was 0.15 mg per kg per day. On day 11, she had, in the meantime, her atrial tachycardia subsided. However, she had one episode of atrial tachycardia at discharge in the past 24 to 48 hours, and she was discharged with sinus. So this is our second case. The second case was a 2-weeker, 35-year-old, 35-week gestation. When he arrived to us, he had fetal SVT, for which the mother was on flecainide, 400 mg BD. Fetal had been reverted, but due to the complications of flecainide, she underwent preterm delivery. 12 lead ECG at birth was normal with a PR interval of 135 per minute, QTC of 330 milliseconds, right axis deviation appropriate for the age. His echo was normal. On day 4 of life, this was the baseline ECG which showed normal, which was sinus tachycardia. On day 4 of life, he had 2 episodes of SVT, which was reverted with injection adenosine, and for chronic therapy, oral propranolol was started. Following the fourth and subsequent episodes of SVT, flecainide was added, 2 mg per kg BD, and he was on dual anti-epileptics, in spite of which multiple SVT episodes were occurring. Then he was switched to oral ivabradine and amiodarone after stopping flecainide and propranolol. And post which he had again, this was the ECG at discharge. So after going through these two case scenarios, coming to the definition of refractory SVT. Refractory SVT is defined as episodes of SVT that do not convert to sinus rhythm despite administration of 2 doses of adenosine at or above the AHA recommended dose. However, unstable SVT was defined as occurrence of hypotension with or without altered mental status or documentation on physical examination or of poor perfusion during the episode of SVT. So management wise, first the epidemiology, the incidence of SVT is nearly 1 in 250 per in neonates. However, the incidence of refractory SVT is 20 to 25%. The various studies show various numbers. The management would be to attempt a vagal maneuver, however, only to buy time. Once the IV access is obtained, we give IV adenosine 0.2 mg per kg IV, and this may be both for diagnostic and therapeutic. The other medications can be used are dexmedetomidine, esmolol, sotalol, proconamide, and amidone. Once the episodes are terminated, we look at the excitation, pre-excitation, and we continue for chronic management of this. Coming to the role of ivabradine in management of atrial tachycardias, ivabradine shows promising role. It's a non-selective inhibitor of hyperpolation activated cyclic nuclear gated channels. Ivabradine has been used in adult in focal atrial tachycardias and multifocal atrial tachycardias. However, there are case reports in which neonatal SVTs are also managed with ivabradine. There is a definite role of ivabradine in congenital junction ectopic tachycardia and post-op junction ectopic tachycardia. The role of ivabradine in tachyarrhythmic arrhythmia and tachycardiomyopathy is well established. So this is how the initial management of SVT is managed according to PALS. So pharmacological therapy, first line pharmacological therapies are beta blockers, second line agents are flecainide, sotalol, and amiodarone. And however, ultimately catheter ablation is a definitive therapy for SVT. The successive rates of SVT is more than 90%. The complication rates are low. So the indications for ablation therapies are recurrent and persistent SVT associated with ventricular dysfunction, recurrent SVTs or persistent SVTs with the when medical therapy is not effective, and recurrent and persistent SVT to avoid chronic antiarrhythmic medications. In case of recurrent SVTs where associated with acute hemodynamic compromises or that requires emergency medical care, also ablation has been done. So the take-home messages for acute management: the urgency of the choice and treatment is ventricular tachycardia depends on the patient's hemodynamic status. Evaluation of the episode after the episodes, and chronic management, pharmacological therapy, role of ivabradine, and role of catheter ablation is to be emphasized. Thank you. These are the doses.
Just small questions from the cardiology side. Is always this resistant SVT in this newborn atrial tachycardia? And the second one is because I saw in it, both your cases, this flecainide was started. Is like flecainide the drug of choice to start as a first management?
I think it's an important question which you have raised, Nehal, and I think flecainide has been underutilized. So flecainide is a good drug for SVTs, and as long as we know that it's a structurally and a functionally normal heart, flecainide can be safely used. So I think we used to fall back on amiodarone, digoxin, beta blocker. These were the fallback drugs in the earlier era. But now we tend to use after the first line drug. So first line drug could be AV nodal blocking drugs. And if they don't work, then flecainide is definitely a good choice. So flecainide for reentrant tachycardia. So if it's an axillary pathway mediated tachycardia, if it's an AV nodal reentrant tachycardia, if it's an atrial tachycardia, flecainide definitely is one of the good drugs to be tried. My question or my submission is that you have stressed on the role of ivabradine. I think ivabradine and supraventricular tachycardia, I would still feel that we don't have robust data. So that should be literally left as one of the later therapies. So you start with AV nodal blocking drugs, beta blockers, the drug of choice. You go to flecainide. You may consider amiodarone. and ivabradine has been reported in atrial tachycardias and focal atrial tachycardias, but I'm not too sure about it being used in the reentrant variety of tachycardias, because some of your tachycardias, adenosine worked and terminated now. For such a, if you have a strong suspicion of an axillary pathway mediated tachycardia, I doubt whether ivabradine would have a role, or a multifocal atrial tachycardia, whether ivabradine. So I would have, at least I don't have much experience, and I don't think that. Namudri, what would you think as the role of ivabradine?
Yes, sir. If we consider the effect of ivabradine based upon the mechanism, macro reentry, it has no reason to add. Amongst focal tachycardias of the three, in pediatric population, somehow the automaticity related atrial tachycardia is much more as compared to adult, where in fact micro reentry and triggered activity predominate. So in these cases, in pediatric age group, probably there is a higher role for ivabradine. Some of them respond very well, but ivabradine sensitivity should be defined in isolation, like posterior vesical AVT response to verapamil. But if you give this beta blockers, digoxin, flecainide, amiodarone, and then add ivabradine and it responds, probably it may not be ivabradine sensitive. So my strategy is generally in patients, otherwise children, otherwise having suspected focal tachycardia, structurally normal heart, not in LV dysfunction, I give a trial of ivabradine initially. If it works, it works. If it doesn't, there is no role for ivabradine. This is my strategy, but overall it is the context is similar to what you mentioned. This is a small aberration in practice that I do.
Thank you. Ajay, any comments? Should we move on to the last case?
Yeah, I think we can move on. I just echo what Dr. Nambudri said. Beta blockers primarily, and then ivabradine flecainide for atrial arrhythmias, and for reentrant, the other drugs. Yeah, I'll just move on. We'll move on to the other.
So one point I just want to make, like ma'am asked whether all these reentrant are atrial tachycardias. We can still have these reentrant refractory tachycardias also. One of these actually was reentrant, the other one was atrial tachy, which we managed. With regards to that ivabradine, yes, we don't use it in reentrant, and even but in adenosine sensitive AT, it is noted to be very useful. So this particular the first baby, actually we did adenosine, although knowing that there was a sort of a long RP tachycardia, just to make sure is there any atrial flutter underlying there or not, and we found that on the which I think you did not put on the slide. So we found that there was atrial tachy running, not really atrial, and then it flipped to sinus rhythm. So we started ivabradine. The and what happens is when they come to us either referred from other centers, already amiodarone is on board, started by the pediatricians. So just once the amiodarone is there, we don't have much things to manipulate around. So we have to either work with one drug at the most, just because the interactions are too much. But FLEC also we start at a lower dose and then see the response, QRS, QTC, and then take up. In that situation, the beta blocker effect does help. But sometimes it is overwhelming. So ivabradine, we have seen much effect in the post-op jets, exceptionally well effect. But so this was like we also trialed this in some of the new units, and it's so now actually the follow-up patients are on FLEC and ivabradine only. So I don't know what is working, but yes, they are asymptomatic now.
Thank you, Kishore. Let's move on to the last presentation of the day by Sneha Keswani from Holy Family Hospital, Bandra. Sneha, your presentation, Epstein's anomaly with a normal ECG. Kishore, can you unshare your presentation? Sneha, are you ready?
Yes, sir.
Can you share your presentation?
Yeah, just doing it in seconds. Are my slides visible?
Yes, now go ahead.
So, good afternoon, everyone. I'm little naive to this region, so just bear with my nervousness. I'm little nervous, but I will try my best to do justice to the topic. So, my topic for today is a case presentation of a Epstein anomaly with a apparently normal ECG. So, this was an 8-year-old boy who presented to us. He was detected to have a murmur since infancy, but it was told to be physiological. But since 1 year of age, child started experiencing fatigue and breathlessness on excessive exertion. And along with since 1 year of age, followed by since 3 year of age, it was also associated with intermittent facial puffiness and bilateral pedal edema with surprisingly spontaneous resolution. But despite all of these symptoms and recurrent episodes, family did not pay much heed to it and no medical attention was sought in all these years. After so many several episodes, finally they went ahead for the medical evaluation. Now, at this point also, patient denied any history of any palpitations or near syncope. On clinical examination, we got a grade 2/6 pansystolic murmur in left lower parasternal area, which increased as inspiration with no palpable RV inflow pulsations. Followed by the clinical examination, this was the ECG of the child on presentation, where we can see a fairly normal P wave, a PI interval, narrow QRS with an axis of almost minus 40 degree. Along with that, what we can see is the RS pattern in the inferior leads and prominent Q waves in lead 1 and AVL. Along with that, we can see physiological T wave inversions in the precordial leads also. This was all about the waves. And regarding the rhythm, it is a sinus arrhythmia with intermittent junctional complexes. After ECG, we moved on to the echocardiographic evaluation. So as we can see, a apical 4-chamber view showing a dilated right atrium and a right ventricle with tethering and the apical displacement of the septal tricuspid leaflet with fairly intact interatrial septum in this view at least. Along with that, how much was then the apical displacement? It was approximately 27 millimeter apical displacement of the septal leaflet. And we can see here the 3 chambers, the right atrium, atrialized right ventricle, and the functional right ventricle. Apart from the septal apical displacement, we can see the tethering of the posterior leaflet also. In this parasternal long axis RV inflow view, we can see the tethering of posterior tricuspid leaflet, and we can also notice a moderate to severe, fairly severe only tricuspid regurgitation. So this finished a complete clinical and echocardiographic assessment, and child was diagnosed with Carpentier type B Epstein anomaly and was planned for surgery. As per the routine protocol of the center, child was referred to us at this point for pre-operative EP study. So before proceeding for the EP study and what we did further, what are the classical ECG signs of Epstein anomaly? So let's discuss this as per the framework released by PACES HRS in 2014. So I will like to start with P waves. P waves atrial enlargement we can see with Himalayan P waves with a maybe normal, maybe prolonged or a short PR interval. But the important point is here PR prolongation is not due to AV nodal delay. It is due to prolonged intra-atrial conduction. Hence, the PR segment is normal. It is the P wave which is longer, followed by the QRS. QRS, we get a atypical right bundle branch block pattern with a normal axis. But if we get a left axis deviation, that can be one sign of the presence of pre-excitation. Apart from that, what unique features we get? Indirectly, we can left axis deviation only what we say the presence of Q waves in the inferior leads 2-3 AVF and the anterior leads can be a sign of inferoparaseptal pre-excitation. This was all that. Then what are the rhythm abnormalities we get? So the rhythm abnormalities are, it can be a normal sinus rhythm and different types of supraventricular tachycardia, atrial arrhythmias, and very rarely ventricular tachycardias we get in Epstein anomaly. This was about the classical ECG features. As we discussed that child was sent to us for the pre-operative EP study. So let's discuss what are the indications of EP study in Epstein anomaly. So as per again the 2016 PACES HRS consensus. The classical three indications of EP study in the cases of Epstein anomaly are evidence of pre-excitation, maybe with or without symptoms, any documented or suspected arrhythmia, and all the patients who are going for surgery as a pre-operative assessment. So moving on, so as per initial plan, we proceeded further with the EP study. So here we can see we positioned our decapolar catheter in the coronary sinus and a quadripolar CRD2 catheter at the his position. You can see the position of a catheter in the LAO 40-degree view. After the positioning, let's move on. What were the findings? So we started with the atrial pacing with as we can see a surface ECG and a simultaneous intracardiac signals of the atrial pacing from the coronary sinus. As to mention, we are pacing from, we can see we are pacing from the electrode 3 and 4 of the coronary sinus. So we are able to see a very clear H and V signal with a gap in between, which is not normal, relatively short only of approximately 27 milliseconds. But there is a significant gap during the pacing, which completely disappears further. After cessation of pacing, we are able to see almost zero HV interval. That his signal has been completely merged in the ventricular signal. Apart from that, what else we are able to see in this intracardiac is this non-pre-excited junctional beat. Moving on, we proceeded further with more rapid pacing at a cycle length of approximately 300 milliseconds. As again we demonstrated this, we demonstrated a overt pre-excitation, or we can say a maximum pre-excitation, and his signal clearly disappearing into the V signal. Again, we demonstrated the same phenomena with, now this we are demonstrating with drivetrain followed by an extra stimulus. We can see the drivetrain at 450 milliseconds followed by extra stimulus testing. Again, demonstrating similar phenomena of maximum pre-excitation, which shows clearly its signal disappearing in the V. After the pacing, let's move on to the tachycardia. So this was the surface ECG of the tachycardia induction, where we can see we proceeded with extra stimulus testing with the pattern from the coronary sinus, and the pattern of the QRS which we are able to see is negative in AVF and a positive in lead 1. Initially, tachycardia was not inducible, but with repeated multiple extrastimulus testing, we were able to induce a regular wide QRS tachycardia with the QRS morphology consistent with the morphology of the pre-excitation pattern. So at this point, a differential diagnosis for this regular pre-excited tachycardia, which we took into consideration, was antidromic tachycardia, and second was a pre-excited atrial tachycardia. So this tachycardia actually terminated quite early after few seconds in a QRS complex, and it was not reinducible. So before we discuss the intracardiacs of this tachycardia, apart from R2 differential, what are the other differentials of pre-excited tachycardia? So the other differential are atrial fibrillation, atrial flutter, and very rarely AV NRT with a bystander accessory pathway. So keeping in mind our differential, let's have a look on intracardiacs of our tachycardia induction, where we can see the first beat again is a non-pre-excited junctional beat, followed by the extra stimulus testing, which showed increasing pre-excitation until it induced the tachycardia with A, V, and A initiation pattern. Again, this narrowed down a diagnosis to the same two differentials, that either it is an antidromic tachycardia or it is a pre-excited atrial tachycardia. So during atrial pacing, we were able to map earliest ventricular activation to be along right inferoparaseptal region, and accordingly we positioned our catheters. We can see the ablation catheter in the RAO and the LAO view. Apart from that, what else we are seeing in this is to see in this is the RF signals in the bipolar and the unipolar. In the bipolar, we are able to see continuous electrical activity between A and B wave in the bipolar signal, and along with that, in the unipolar, we are able to see early negative unipolar signal, which is approximately 50 milliseconds earlier than the QRS. After the mapping and position, we proceeded with the RF energy. So we can again here see the continuous electrical activity, but this was followed by no V wave and only a wave, and which was followed by a junctional escape. And after which we are clearly able to see a normal conduction with a complete, totally separate H and V signal. So we finished with our ablation. After ablation, with RV pacing, we demonstrated there is the absence of VA conduction. Now, this absence of VA conduction demonstrated that that pre-excited tachycardia has to be a pre-excited atrial tachycardia. Along with that, with adenosine, we induced a AV block which showed no residual antegrade conduction through the accessory pathway. So here we confirm no retrograde or antegrade conduction through the accessory pathway. So after finishing the ablation, what changes we notice on the ECG as compared to the pre-ablation ECG? So in the pre-ablation, as we have discussed earlier only, we were getting RS complexes in inferior leads, which was now changed to RS R dash pattern in the inferior leads, as we can see in the post-ablation ECG. Second thing which we were seeing in the precordial leads, we were able to see RS signal in lead V1, we can say, which was now changed to RS R dash followed by small S dash pattern in the post ablation ECG. So this was about our case, how the child presented, how he was referred to us, how we evaluated and further managed. Now let's proceed. What does the literature say about this topic? So this was one of the initial case report study done in a pre-excited tachycardia in a patient with Epstein anomaly, which showed that if in a case of Epstein anomaly with RV enlargement and there is absence of RBBB, then we have to suspect that there might be a presence of accessory pathway. One important point to be noted at this is with normally with WPW, we get a wider QRS, which change to narrow QRS after the ablation. Elsewhere in Epstein, we see totally opposite of that. In the Epstein with WPW, we get, as we can see here also, we are getting a narrow QRS before ablation, which becomes a wide QRS after the ablation. Now, what is the reason of this wide QRS? This wide QRS is due to the right ventricular conduction delay, which was masked by pre-excitation. When we removed the accessory pathway, it got unmasked. Along with that, what this this report quoted that patients with atriovesicular pathways have no delta wave in sinus ECG because of the slow conduction in the pathway. Then this was a paper presentation. It was only abstract. It was a retrospective analysis, retrospective study of almost 600 patients, which aimed to first assess the prevalence of right bundle branch block pattern in the patients with Epstein anomaly. Along with that, what they examined is the correlation of its absence and the presence of accessory pathway. So they moved further, dividing the adults with Epstein anomaly in 3 groups. The group 1 was with the right bundle branch block pattern. Group 2 was with the left bundle branch block pattern, and group 3 was a normal QRS. But we don't know, the no details are available that what authors have taken into consideration saying the normal QRS. So we can't decide completely. But what were their findings? They noted that 22% of the patients with RBBB had accessory pathways, and only 30% of the patients with normal QRS and absent RBBB had accessory pathways. Then we concluded that almost a large group of patients with normal QRS and no RBBB had absence of accessory pathway, which is completely contradictory to our conventional wisdom, which says absence of RBBB has a very high predictive value of the presence of accessory pathway. And in this study, they quoted that absence of RBBB may not increase the risk of underlying accessory pathway. That was quite confusing. So let's move on to the next study, which was confirmed in the same with the conventional wisdom. This was again a recent study only of 2024, first, which showed that Epstein anomaly can present with varying types of arrhythmias. It can be AVRT, it can be AVNRT, it can be atrial arrhythmias, and very rarely ventricular tachycardia. But most importantly, it quoted that absence of RBBB at baseline had 91% positive predictive value for the diagnosis of accessory pathway, and this was with almost 98% sensitivity and 92% specificity, as they have mentioned. Apart from this, what they have given is the prevalence of different types of what is the prevalence of different types of arrhythmias in Epstein anomaly. As we can see here, the most common are it as equal as atrial arrhythmias and AVRT are almost equal, and the most common arrhythmias in Epstein anomaly, and the most rare, the least common arrhythmias are the ventricular tachycardia. Then moving on to the last study, this was a study conducted in our San Antonio Holy Family Hospital by Dr. Yagnik. This was a study of 42 patients of Epstein anomaly who underwent the EP study. This has been already published in IHRS 2022 with a data of 27 patients. What was the aim of this study now? So this study aimed first to find a correlation between electrical and structural severity in Epstein anomaly. Also, it devised the scoring system for the electrical abnormality as well as the echocardiographic severity. But what they found was that there is no correlation between electrical and structural severity. Apart from that, what were the findings? Were that they reconfirmed that the most common location of the accessory pathway was the right inferoparaceptal, or called as a posteroseptal region. Along with that, they also grouped how many had multiple pathways, how many had single. So the major group of 34 patients had a single accessory pathway, and only 8 patients had multiple accessory pathways. So this was all about the literature regarding this topic. So to conclude, Epstein anomaly with right ventricular enlargement and a significant tricuspid regurgitation, there has to be some signs of RV enlargement or delayed conduction or both, which has to be seen present in the ECG. Apart from that, if in a frank case of Epstein, we are getting a normal ECG, that is a very important sign that delay has been masked by a presence of an accessory pathway. And if we get an accessory pathway, it has to be tackled before surgical repair to avoid nasty intra and post-operative complication. Also, if we are proceeding for ablation or planning for mapping and ablation after surgery, the mapping as well as the ablation both becomes very difficult in the post-operative period.
Okay, thank you, Sneha. Very, very good presentation from for us, especially for practically treating this kind of children. Just want to know a consensus that everybody does a EP study prior to surgery for abstinence. Is the consensus amongst us?
So I don't perform. I mean, I don't perform in the sense that the surgeons used to ask me to do an EP study, and I did in the initial phases EP study, and there were good number of half a dozen patients where I couldn't find anything. So I, in fact, convinced my surgeon that there is no need to do a routine EP study for patients undergoing Epstein's surgery. We can screen them by both these techniques. One is any suspicion, any history of palpitations, any ECG record of any tachycardia, surely yes. Any ECG which is not in keeping with the Epstein's, then also I say that we should do it. So that's been my philosophy. But obviously, Yash has been doing otherwise. Nambudri, what is your take?
I agree with you, sir. Unless this patient had a palpitation or the patient has got any evidence of the pathway. We have done nearly 100 cases so far, and we have found out concealed bypass tract in Epstein only in one case. So I think that approach holds true. even in our experience.
Actually,
On
actually,
a
Amit,
lighter
even
note,
my policy. Sorry,
Sir.
Snehal, can I make a comment?
yeah, sure.
Actually,
I'm
Amit,
not audible.
even I don't do routine. In fact, if a patient has an obvious dilated RA and atrial arrhythmia, which then also I don't do EP study. So I only advise EP study when we suspect an accessory pathway or some other ablatable arrhythmia.
Okay, well, I think Yagnik's study was, I thought, as a routine EP study prior to Epstein surgery.
No, it's not routine. It was those who we
Okay.
Okay. Yeah.
So when we presented our data in IHRS last year, the whole US team attacked me. They said it is important to do an EP study before, and I had to defend all alone. But I think the Western practice is to do EP study in all Epstein before surgery.
On a lighter note, I asked this question to Mauli once. So Mauli said, if they come to me, I do EP study, and all. If they go to surgeons, they directly go into the operation table. So this is on a lighter note by Mauli. But actually,
But
we are very worried about the atrial arrhythmias, and therefore our indications for surgery by between 3 and 5 years, most of our stents get repaired. Because longer we wait, the right atrial dilatation and atrial arrhythmias will face a bigger challenge, I would say, and may be difficult to control.
So,
Yes,
Nambutri, do
Snail.
you have any experience in terms of doing ablation post Epstein's surgery correction? Post Epstein correction, is the ablation more difficult? I mean, I just want to understand that.
Yeah, yes, sir. A couple of cases we had failed ablation prior to surgery. In 2 cases, somehow it was not channelized to the electrophysiology division and patient ended up having surgery. These cases had extremely difficult perioperative course. Even surgeons were not able to complete the surgery because of the arrhythmia, putting into bypass and all were difficult. So these cases, based upon the ECG, in 2 cases were not evaluated, we ablated surgically, and one of them worked and one failed. Post-operative preoperative mapping cases, all we attempt during surgery, and again the chances out of I think 3, 2 had success, 1 failed. We had attempted these 2 cases post-operatively, and few cases done elsewhere also. Success rate is around 50%. I think it is not marginally, it's not very difficult even in, because most of the time surgery will be, whether it's cons repair or not, it is reimplantation of the valve, and it's not very difficult to, they don't do a transmural surgical approach many times. So it's not difficult to me, my
And
knowledge.
that's what I would think, that, perioperative, I can understand the arrhythmia storm may create a problem, but otherwise electively one could later on definitely do ablation if there were arrhythmias coming up in a corrected Epstein's, because it's not like a metallic valve and stuff like that which should prohibit you from doing it.
In fact, catheter stability and all should be probably better because of the,
No, but sometimes we do have a bioprosthetic wall in the tricuspid position. Then does it make any difficulty?
So
Yes, especially if there is atrial flutter and all, I would rather tackle it prior, because some of these patients will undergo a valve replacement, and then getting to the isthmus and all becomes an issue.
No, I think pre-existing tachycardias should definitely be tackled before the surgery. Not having tachycardias and routine doing, that was my concern, that some of them may have the pathways and some of them may turn out toward SVTs. But post correction of Epstein's, it should be possible to ablate. And bioprosthetic valve and doing surgery ablation should not be a major concern. Snail, do you want to conclude?
Yeah, you can. Yeah, both
No,
can.
go ahead and
Thank you
conclude.
very much for making us a part of this. And I personally feel even Epstein can be a complete discussion or a complete session in itself, because there's so many anatomical variants, the different kinds of surgeries at different phases, the post-operative arrhythmias after Epstein's, especially the atrial arrhythmias, is a major challenge actually. And I think there has to be a consensus amongst us, and because many people do not know actually, to be very honest, when to do and what to do. So it can be a session in itself actually. But thanks a lot for getting all of us on the board and giving pediatric arrhythmia some kind of a face on your specialty. We really need your help a lot. Amit?
No, I think it was a wonderful session. Thanks to all the presenters. They did a good job. And thanks to all the moderators. Deepchand, do you have any last comments?
No, sir, all good. Thank you all for your presence and taking time out today.